Great. So let's get
Good.
started. And this is a critically important topic. And one of the things I promised myself, I'll not make fun of psychiatry and psychiatrists too much, but we have to rethink our model. And there's not a kind of better merger of my thinking and what Rupa does in terms of testing than understanding, I think, the completely misunderstood tragedy of antidepressant withdrawal. And it pretty much starts here. Psychiatrists, nurse practitioners, family docs, anybody prescribing psychiatric medications have no training whatsoever in how to stop them. And that is the crisis. That's the journey I'm going to take you on today, at least bits and pieces. No one is trained how to stop these medications. So what's happened is everyone's making educated guesses and it's not working well. And this is the question that, hit me about 10 years ago as a pretty experienced functional medicine psychiatrist, where since then I can pretty much tell you that in my practice as a clinician, as a consultant, I do not experience antidepressant withdrawal. So I've eliminated from our practice. And I just read this slowly. And I just want you to think about it, particularly if you're a prescriber. Why do some individuals stop antidepressants without side effects and others go through this tremendous withdrawal of insomnia and irritability and anger and brain zaps and even intense suicidal ideation? Okay, so I'm just going to say it again. Two people on the same antidepressant for the same amount of time. Why does one person develop these horrific withdrawal symptoms and the next person doesn't? And when that kind of light bulb went off for me, probably about 10, 12 years ago, I was able to prevent antidepressant withdrawal. So by asking that question, and anybody that's prescribed, answer that question for yourself, you'll be able to appreciate it is not the medication. So we can't just blame this antidepressant, this SSRI, because not everyone withdraws. We have to reframe our thinking, our focus, the paradigm to looking at the individual. And that's what functional medicine is all about. That's what testing is all about. And that is the model of how to support someone with antidepressant withdrawal. So these are just three cases that I saw. It was right probably the year before COVID when I wrote this up. And we're going to talk about them at the end. But 30 years on Paxil, a 40-year-old, I'm sorry, 6 years on Paxil, a 40-year-old, 1 year on Zoloft, and a 50-year-old, 15 years on Prozac. Now, they all got to me because they could not withdraw from these antidepressants with their current prescribers. And what I'll share with you to help them all get off their medications was a completely different approach based on functional medicine testing. What happened to these individuals when they went to their doctor or psychiatrist? They all had this different concept in their head. These are some of the things our psychiatric community thinks about. What about cross titration? What about just adding supplements? What about giving a benzo? What about taking another SSRI? What about a gradual taper? It kills me when I see these protocols where people talk about decreasing a medication 10% every 2 weeks. And that is what we're going to question and even make fun of, because the absurdity of predicting a percentage of decrease makes no sense when you look at a functional medicine model. And I use this slide with introducing this concept because sometimes I use it to share with my colleagues of what it's like is we're just prescribing medicines and patients can't come off it. But oftentimes it's more for so many of our patients that are just placed on revolving antidepressants. Everyone's afraid to stop them because they don't want withdrawal. So we need a little background and a little history before we get into the model. We've heard the word crisis. This is a global phenomena. Depression is the number one cause of disability worldwide. Think about it. Worldwide. So just a leading cause, meaning heart disease, kidney disease, autoimmune disease, is not as disabling as major depressive disorder. Numbers are increasing, and our treatment model is pretty stagnant. And what's more frightening and tragic is 75% of individuals in the low income countries receive absolutely no treatment. So it's a real problem. We think of the hundreds of millions of individuals, and then we think of the efficacy of our medications. I used to have a slide with an M&Ms saying that some of the studies are pointing to 50% efficacy of antidepressants, which means if you took M&M, you might get the same result as some of these antidepressants. Better studies in the better hands, maybe 60% improvement, but not everyone gets better. And the side effects are disabling and the relapse rates are really high. So to understand withdrawal, we have to understand what the difference is in our psychiatric community versus our medical community. So if you had a severe headache and you've never had headaches before and it was just getting worse, what would you do? You might try taking Advil, but if it didn't get better and you were getting dizzy, you would head to a doctor. And that headache in the doctor's mind could be any of 10 things. In your mind, it's only one, that you have this brain tumor and you're frightened to death. But our medical model is we're going to measure the physiology. We're going to do blood tests and CAT scans and physical examination to understand what might be contributing to that headache. And the treatment for brain tumor is going to be different than a migraine and different than a stress headache and different than a concussion. And then based on what we find in this medical model, we're going to provide different treatment. That's the medical model that you and I appreciate. Maybe it's overdone for chronic illness, but certainly if you're in the emergency room, certainly if you're in distress, it is incredible. And this is our model of psychiatric treatment. What are we doing? We're just taking educated guesses. If you come in and you're sad and that's your symptom, nobody's looking at why or what the etiologies. There's no blood, urine, hair, stool tests in our traditional model. You're sad, so we're just going to give you this anti-sad pill, right? So you get an antidepressant, and we're going to ask if you're feeling better. No concept of underlying etiology. And this symptomatic based model, which I'm sure so many of you are familiar with, is what just leads to this over kind of indulgence in just handing out medications. And the tragedy is you get a simple visit, someone comes up with a diagnosis, you're depressed, and you get a pill. It's our fast food mentality of mental health treatment, and it's only growing with more medications, more awareness, more therapy, but more suicides, rates of depression, and relapses. Essentially, we have no tools to help prescribers, so it is nothing more than educated guessing. The side effect profile is long, from weight gain to sexual side effects that is incredibly challenging for many to talk about or to stay compliant on the medication. Or I can't tell you how many people have chosen, do I want to have a relationship with my spouse or not be depressed? And this I just use as an example because it's an international study, 33 countries. The side effects of the medications. We talked about sexual side effects, two-thirds, not feeling oneself, this concept of emotional numbness, not feeling the joy at a wedding or the grief at a funeral, not shedding tears are the direct result of these antidepressants. We could go on and on, suicide, addiction, but what we're talking about today is the syndrome of antidepressant withdrawal. And here's almost 60% experience antidepressant withdrawal. And in this one study from New Zealand, only 1% of individuals prescribed antidepressants were ever told that withdrawal might be a problem. And then here again, it's over 17 million individuals. Okay. In terms of the question of efficacy, no significant difference between those that took the antidepressant. So it's unclear if it improved quality of life over time. Now, I haven't thrown away my prescription pad. I use antidepressants, but my model, which you'll hear about in terms of getting off and everything that we talk about in psychiatry and fine, is functional medicine testing. Understand what may be contributing to the depression, to the irritability. So I've been starting off all of my talks now, acknowledging we have a crisis, but helping people reframe that it's not just a mental health crisis. It is a crisis of mental health care, right? The model just doesn't work. And this is what we're trying to avoid is this fast food symptomatic based prescribing that generates the side effect profile and this really horrific antidepressant withdrawal that we're going to get to. Well, before we talk about antidepressant withdrawal, I think it's worth just going back a little bit to talk about our old friend Valium, which has a pretty kind of similar history to the evolution of Prozac in the 1980s. In the 60s, Valium, which actually was the same company, Purdue, or the company before Purdue, that started marketing this. So it's pretty tragic. So it was mommy's little helper. I used to care, but now I take a pill. So Valium was the drug of the 60s, mostly for women, first $1 billion drug. And doctors jumped on board because it was simple and it was safe. And guess what? People felt better. And then we had our medical community, particularly Harvard Medical and the Department of Mass General Hospital. So we had the chief of pharmacology at Mass General Hospital, 1976. I never saw a case of benzodiazepine dependence. Addiction to Valium is an astonishing, unusual event. Okay. So it was a pharmaceutical company. It was marketing to consumers. It was physicians believing it was simple and safe. Now they had a tool, and it was only 14% of Americans for Valium, the non-addictive pill. But it was the New York Times that started the discussion, right? 1974, Valium was questioned as maybe there's some concept of addiction. So we're going to come back to the New York Times in a minute. But Prozac had a similar history. It came out of training in the 80s. We had this miracle drug. Are you shy? Prozac can help. Listening to Prozac came out. It was the miracle cure, no side effects. But eventually, we had TV shows of Prozac survivors. We have Prozac Nation, and we had this backlash of concern. But the doctors weren't budging. Again, back to my friend, the New York Times started questioning the antidepressants, and they wrote an article about maybe these drugs are hard to get off. Maybe there are withdrawal symptoms that patients were never warned about. And there were some authors who were able to make the obvious connection. Withdrawal reactions to antidepressants, SSRI, seem to be similar to those of benzodiazepines like Valium. 37 and 42 identified symptoms were identical. But it was still a challenge from medical colleagues to accept it. Patients had to start their own groups for support to help individuals get off these medications. These are peer support groups surviving antidepressants. These are individuals that got off medications, that struggled, that suffered, and are trying to help others. So these are some are nonprofits, but this is what the consumer did. And our community of prescribers were far behind, but then there was some pressure. And so what did psychiatry do? Any marketing people out there? We decided to rebrand this problem. And how did we do that? We said that the coming off these medications, it's not a withdrawal reaction, because that sounds too much like drugs. And we don't want people to think these antidepressants that are selling billions of dollars. And I think I heard 1 in 6 individuals now in this country are taking psychotropic medications, mostly antidepressants. So we'll call it discontinuation syndrome. It sounds better, right? It's not withdrawal syndrome. And we got a little help with the naming, right? This was a committee on safety of medicines in the UK, and Eli Lilly, who had the patent on Prozac, put a little leverage on this committee. And Lilly expressed concern about using withdrawal reaction. And Lilly, the pharmaceutical company, suggested the term discontinuation syndrome. In the psychiatric literature from the late 1990s, you do not hear withdrawal syndrome. Even though you talk to a patient, it is unbearable, these symptoms, and it is a withdrawal from this medication. But the community of psychiatrists and researchers now have used this term, antidepressant discontinuation syndrome. And some people say the obvious, referring to these reactions as dependent syndrome. Benzos, but not for SSRIs, does not seem rational, right? We're talking about you stop the medication you have, and here's some of the symptoms: sweating, heart palpitations, sensory disturbance, headaches, insomnia, lability, irritability, suicidal thoughts, agitation, brain zaps. I mean, these are so debilitating. Many patients have to rush back on their antidepressants to eliminate this syndrome. Okay, so it exists. Now our colleagues can write about it. We don't call it withdrawal. We can call it antidepressant discontinuation syndrome. So what do you do if a patient comes in your office and wants to get off these medications? People started looking at what's the best to do. So they looked at the research, and here's, a meta-analysis, it's called, looking at reviews and panels and case reports. And guess what? Everyone's recommending something different. Reduce the dose by this percentage, 4 months, taper, 6 weeks taper. Just a hodgepodge of studies, but no definitive consensus and no research. And then it gets even better. Everyone's saying to taper, and this 15 controlled trials, author's conclusion: an advantage of gradual tapering compared to abrupt discontinuation did not emerge. Another one, gradual tapering did not eliminate withdrawal. The information overload of people doing these random studies on how to taper someone off an antidepressant was completely disorganized. And everyone had a different theory. And this is pretty much what it's like. So everyone just had their own uh, pet protocol. I teach a lot of psych residents, and we always talk about antidepressants. And when we discuss the withdrawal, they all have these completely different concepts of what to do. And they're very emphatic as what they are. And I always ask them, where'd you hear that model? That's what my supervisor told me. And 100 supervisors are telling 100 residents something different. And so it's a bit overwhelming. And this is my favorite American Journal of Psychiatry a number of years ago. This is the model they're recommending. It is a little absurd and overwhelmingly confusing. And then here's the tragedy of modern psychiatry. Again, the American Journal of Psychiatry, the most respected journal in the field when discontinuing antidepressants. As depression is a chronic disorder, we recommend continued indefinite treatment to reduce the risk of relapse. So essentially, since we don't know how to take someone off these medications, guess what? The next step is just say, take these medicines for life. If this is not absurd, I don't know what else is. So again, these are some of the options people are utilizing, from therapy to longer actings, to adding more medicines, to switching medicines, to exercise. None of them are sufficient. And we're going to go back to how I started. Functional medicine is defined by this concept of genetic vulnerability and environmental insults, leading to everybody is unique. And I'll go back to my first slide. It's not the Prozac, is the individual's reaction to coming off Prozac. So this is our model of biochemical individuality. So let's start. So we think of these SSRIs. We do know they affect serotonin synthesis. Do know there's some controversy if serotonin is the actual major factor in depression, but we do know these medications affect serotonin synthesis. So a functional medicine model that you need to embrace to support antidepressant withdrawal is to memorize the synthesis of a serotonin pathway and all the vitamin and mineral cofactors. Understanding this has essentially eliminated antidepressant withdrawal for the last 10 years of my practice. Okay. Now, we're not going to have time to talk about all of the cofactors that go into serotonin synthesis. We're talking about just a few. But this is the slide that I need you to appreciate. We get L-tryptophan from our diet. It's an essential amino acid. So you need to eat protein. And then we have vitamin and mineral cofactors for the synthesis of serotonin. And you see here, these are B vitamins, trace minerals, some that aren't even here, zinc, magnesium, lithium, all required to make serotonin. So remember that. We'll come back to it. So this seems obvious, and it's sad that we have to keep repeating it. But if we take a medication that's going to disrupt serotonin for prolonged periods of time, like our patients on these medicines for 3, 5, 10, 20 years, there has to be physiological complications or disruptions, right? Because SSRIs block the reuptake of serotonin. The body adapts to that. And what happens is there an overall decrease synthesis of serotonin. And we haven't done any brain studies on people that are alive, but we've done enough studies on looking at rats. Okay. And what we're able to see is that serotonin levels are almost 50% reduced in certain areas of the brain when we stop these SSRI medications. Okay. Again, it seems obvious. It's just not part of my colleague's treatment model. If you take a medicine that disrupts physiology for a long period of time, our body has to adapt. But a part of that adaptation is getting the agent that's messing up the typical response. So our body is adapting to have a foreign chemical, if you will, prevent the reuptake of serotonin. And our body has a physiological adaptation. So it would make sense that removing that agent, there would be dramatic changes in the physiology of the brain. It doesn't happen to everyone. Okay. It happens to some individuals. What we're going to do, just go through some of the core cofactors for serotonin synthesis that we understand might affect withdrawal, or certainly my clinic experience treating thousands of patients over the past almost 30 years. So we'll start off with the amino acid precursor, tryptophan. So you have to have adequate protein in your diet. You have to have adequate digestive enzymes like HCl to break down the protein. And then we're going to talk in a minute, vitamin D is the first cofactor to make 5-HTP. So the brief summary here is we need adequate protein. We can test for that looking at plasma amino acid levels. We need adequate digestive enzymes, and usually looking at adequate levels of hydrochloric acid and zinc, which is a cofactor of hydrochloric acid. And then we need to make the precursor 5-HTP. So in a antidepressant withdrawal model, we sometimes use tryptophan as a precursor to serotonin that helps with sleep, but it has a feedback mechanism. Whereas 5-HTP is freely converted to serotonin, easily passes the blood-brain barrier, and there's no feedback mechanism. So giving either tryptophan or 5-HTP as the precursor to serotonin is part of the problem. And again, we have multiple other nutritional cofactors that are all critically important. And the work that we do, the book that I wrote, everything we talk about is testing for all of these cofactors. And again, that's a 4-hour presentation. We're just going to talk about some, but I do want to mention vitamin D because one, it's a simple test. The implications are profound. We have so much talk about vitamin D and immune system and bone health and maybe even stimulating genes, but nobody is discussing the role of vitamin D and brain health. So remember that first step from tryptophan to 5-HTP? Vitamin D is that rate limiting step. Okay. It's a cofactor for the synthesis of serotonin. Here it is. So vitamin D is that cofactor. You cannot make 5-HTP, which means you can't make serotonin without adequate vitamin D. So I know many of you test. Our traditional colleagues aren't testing, but testing and repleting with vitamin D has to be a critical step before you would stop anybody on an antidepressant. So we've all seen, I've actually recently seen undetectable vitamin D in a blood test, but we've seen 5, 10, levels of 12. They're not adequately going to be able to synthesize serotonin. They are going to, I guarantee you, have significant antidepressant withdrawal. So repleting with vitamin D will be critical. And in all the tests, I'm going to talk about just a few here today, but I'm looking at repleting micronutrients for at least 2 months, preferably 3 months before beginning a taper of the antidepressant. Okay. And then just kind of labor my point, vitamin D associated with depression, anxiety, and dementia, and dramatically suicide risk. Here's 51,000 adults, vitamin D levels associated with anxiety. And here's 150,000 looking at low vitamin D associated with suicide risk. Again, a simple blood test that has profound implications. There are studies looking at personality disorders like negativity. We have research supporting depression, anxiety, suicide, and a model of prevention, right? So low vitamin D, we can predict all these syndromes. And for antidepressant withdrawal, vitamin D is one of the most common, vitamin D deficiency is one of the most common deficiencies we see in individuals that can't get off antidepressants or have significant withdrawal. The other thing we see all the time is vitamin B12 deficiency. I've been saying it for so long of my concern about some of our vegan, particularly our adolescents, that's not getting adequate B12 and zinc. And it has some profound implications for a whole host of neurological and psychiatric illnesses. Again, for our purposes today, antidepressant withdrawal. And then I don't know if you've been following up some of the new literature on long COVID, but a very well done study completed this year looked at multiple physiological abnormalities in long COVID. And the punchline was that decreased serotonin was one of the most significant variables in long COVID. Serotonin deficiency linking all the abnormalities in a single, very complex biochemical pathway, but very nicely done. Or on the long COVID. So let's go back to our question. Why do some individuals stop antidepressants without side effects and others have tremendous withdrawal? Okay. Can't just say it's Prozac, right? We do know some medicines have shorter half-lives, much more significant withdrawal like Effexor and Paxil. We have to appreciate it is this medication, typically an SSRI, that physiologically disrupts serotonin synthesis, that physiologically causes a functional decrease in serotonin. We stop the medication for those individuals that have nutritional or metabolic abnormalities in multiple aspects of serotonin synthesis will have worse withdrawal. So this is what you have to understand when you look at testing. This is what you have to be comfortable with. So amino acid testing to look for tryptophan, MTHFR testing, folate, vitamin and mineral testing, hair testing for trace minerals, amino acid testing. These are critical. And this model just supports are doing the testing first before you withdraw somebody, right? Some people, again, can get off these medications. Most can't. If someone has struggled, my first line is don't touch the dose. We're going to do this broad range of functional testing. We're going to see what deficiencies exist. We're going to target those that affect serotonin synthesis. We're going to replete it before you taper the medication. Okay? It just simply works. And here's a supplement that we worked on with Pure Encapsulation Serum Plus to help support withdrawal. because as you begin to taper and you begin to have side effects, you have to reintroduce the cofactors and the precursors like 5-HTP and inositol to be able to support that final phase of antidepressant withdrawal. So you remember those three cases, all people that could not get off antidepressants. They came to me because they had debilitating symptoms of antidepressant withdrawal. We did a broad range of functional medicine testing for our first woman, the 30-year-old. She had low levels of amino acids. Okay. So she wasn't, and even though she was eating adequate protein, so she had low levels of amino acids. And we picked up on testing and we gave her digestive enzymes with hydrochloric acid. We gave her free form amino acids. And as we repleted her, then we could start the taper. And for her, she was on Paxil, which is a challenging medication. Again, I do not use any cookbook, particularly around some of the medicines like Paxil or Effective. I have people where it has taken a year, one person, almost 2 years, some people 3 months, some people 7 months. It is individualized. But the concept is always testing, repleting, and then a slow taper based on how that person is doing clinically. And you can't predict. That is why I will continue to make fun of any protocol that tells you how many beads to count or what percentage you should stop the medication or taper the medicine. Everyone is different. Think of zebras, okay? And then the next gentleman, we're not going to be able to go into why lithium, but it was nutritional lithium, 5 milligrams. He had a family history of addiction and mood disorders. So he was given this amino acid precursor, Zero Plus, to help him taper down off the antidepressant and again, successfully off it. And then the last woman was on medications for a long time. She was our Prozac for 15 years, couldn't stop it. And she had the low vitamin D. I believe it was just over 10 at 12. So she was given vitamin D and she was given the OPCs, oligoproencyanids. These are the flavonols, the green tea, the grapeseed, the curcumin. These are these polyphenols that have antioxidant and anti-inflammatory properties in the brain. The point is, everyone is different. Please don't use cookbooks. You can use guides. The goal is functional medicine testing, find out what's going on, individualize the taper based on the testing. And that's functional psychiatry. We haven't thrown away our prescription pad. So we use medications. We understand the goal and the role and the tremendous help of therapy, certainly our lifestyle, genetic vulnerabilities. We look at genetic testing on every patient that we see. There are a number of markers. Again, we didn't have time to talk about it. I mentioned MTHFR, COMT, so genetic testing and nutritional deficiencies. You can safely taper individuals off, and that's the better way, and that's the testing. So I'll wrap up here. Again, they're not trained how to stop them. Oh, here's the textbook. This is one of my few books that written for professionals. So it's protocol driven, going over many of the tests we didn't have time for here. And then Adrian mentioned our fellowship. This is our year-long program. We have a 2-year program where we have both courses, we have supervision. And I think the most enriching, exciting part of our program now is the community. We have hundreds and hundreds of clinicians interacting on a daily basis to support each other and educate.
Hi, everyone. We hope you enjoyed this class. If you're a practitioner, make sure you go sign up at rupahealth.com. And if you like this video, don't forget to like and subscribe.